One.
Welcome back to Advances in the Management of Renal Cell Carcinoma, presented by Albert Einstein College of Medicine of Yeshiva University at OMED Live. You are tuned into today's final session titled New and Emerging Directions in the Management of Advanced Renal Cell Carcinoma. My name is Laurence Albiges, and I am a visiting scientist at Dana-Farber Cancer Institute. For those of you just joining us, today's session is a live, interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I would like now to introduce our faculty member, Tony Schwery, Associate Professor of Medicine at Harvard Medical School. Dr. Schwery is also a genitourinary medical oncologist at Dana-Farber Cancer Institute and Brigham and Women's Hospital. Tony, thank you for joining us today. I will now hand the program over to you to begin our discussion.
Thank you, Laurence. I want to thank the audience for tuning in. It's really an honor and a pleasure to be able to be here to talk about the new and emerging directions in the management of advanced renal cell cancer and how I see the field folding the next 5 to 10 years. So as an outline, we're going to talk a bit about systemic therapy in RCC and the state of the art as of this month. And then how can we improve on the current agent using the same target, essentially the VEGF and mTOR as target, both as single agent, combination, or sequences. Then we're going to shift gears to talk about how can we improve on VEGF targeted therapy. Can we add something else, a new target or novel immunotherapy? So first, what's the field now like in metastatic RCC in 2014? You can see here something we haven't seen for a long time. We have never seen in metastatic renal cell cancer a phase 3 trial with appropriate control arm leading to the approval of multiple agents, both in the first line setting and in patients that progressed on prior targeted agent. This is out of 2004. So essentially, both we have the frontline setting, the patient that are VEGF naive or the patient that progress on prior VEGF target therapy, bevacizumab, the monoclonal antibody against the VEGF ligand in combination with interferon alpha. 2 large trial led to significant clinical benefit in terms of response rate and progression-free survival. Sunitinib, pazopanib, as well as sorafenib in patient progressing on prior cytokine, and temsirolimus in patient with poor risk renal cell carcinoma. Even in the VEGF refractory setting, we have everolimus and axitinib. The question is how to go to the next level here. Do we need a more potent VEGF tyrosine kinase inhibitor? And I'm going to cite 2 experiences, both unfortunately end up being negative with tivozanib and axitinib. And then we're going to switch to combination, whether we should combine these agents. We're oncologists. We usually find a drug that is active, a drug A, a drug B, then we usually combine them. And then we're going to look at the sequence with the latest that we have, focusing on the record tree experience. So in terms of the relative potencies of TKI in RCC, knowing this is thus using biochemical assay, this is where sunitinib, pazopanib, and sorafenib stand. And we may have other TKI that are more specific for the VEGF receptor. Does that mean less side effects and more on target and more efficacy? The first experience is with tivozanib. This drug was looked at in an initial randomized phase 2 study and found to be to have significant activity as well as interesting tolerability. So the phase 3 trial, TIVO1, tested that drug against sorafenib and found an increased and a benefit in terms of progression-free survival, almost 12 months with tivozanib over sorafenib. That met its primary endpoint, which was progression-free survival. Interesting enough, and these are lessons for all of us in terms of trial design, overall survival was not different, and in fact fact, it was higher despite not being statistically significant in the sorafenib arm, which led to this drug not being rejected by the FDA and voted 1-13 against ODAC, was the main reason that the patient on the control arm were allowed to get tivozanib, while the patient on tivozanib were allowed to get other treatment, leading to imbalances in the second-line treatment favoring the patient that started with sorafenib. Another example also is with axitinib. Could axitinib serve as a frontline agent here with more VEGF, more specific VEGF receptor inhibition, more targeted one? That was what the AGILE study attempted to do in a phase 3 trial of only, unfortunately, less than 300 patients. Tested axitinib versus sorafenib, and despite almost 3.5 months, a bit more difference in median progression-free survival, this was not statistically significant. Most likely this was an underpowered study. Can we combine these agents? And initial phase 1 studies showed that the combination, at least with tyrosine kinase inhibitor, had a lot of toxicities, but the combination of temsirolimus and bevacizumab, both intravenous, one an mTOR inhibitor, the other is a VEGF ligand inhibitor, at least was tolerated and showed activity. So the TORAVA trial, after experience in the phase 1 and 2, looked at that combination against the combination of bevacizumab and interferon alpha, which is a reasonable frontline option. And unfortunately, there was toxicity with the bev temsirolimus arm without any added benefit, as you can see here from the median PFS. And therefore, combination therapies is not standard in this disease. The other question that folks attempted to answer is what to start with. I showed you initially the status of the metastatic RCC here, but could we start, for example, by an mTOR inhibitor and go to a VEGF TKI? And that was what a randomized phase 2, a large randomized phase 2 attempted to answer, called the record 3. And the record 3 essentially asked the question whether everolimus is superior to sunitinib, but then looked at the sequence using a non-inferiority design here. In fact, a superiority design, but looking at a specific hazard ratio value to decide whether one treatment is not inferior to the other. As you can see from the primary endpoint of progression-free survival, first line sunitinib was in fact superior. Looking at several subgroup here, good risk, poor risk, as well as at other endpoint beside progression-free survival, overall survival, showing most of that, in fact, all the time here, hazard ratio was higher than 1.1. So everolimus cannot be recommended, the oral mTOR inhibitor, as a first-line option in the average population overall. Next, focusing on patients that progress on first-line therapy. Let's say someone started on sunitinib, a reasonable first-line option, gets 10 months, 11 months benefit, and then patient has to switch. Two drugs here ask the question, both everolimus and axitinib, but these drugs were not compared head-to-head. Everolimus, in a study that was several years before axitinib, was against placebo, and axitinib study was against sorafenib. Both showed benefit, both drug approved in the second line setting. The only thing we have currently is this trial, INTERSECT trial, which tested a different drug, temsirolimus and sorafenib. So it's not everolimus, it's a different mTOR inhibitor, and it's not axitinib, it is sorafenib. And while the primary endpoint, which was the progression-free survival, was not different between both agents, interestingly, overall survival at this time, for unknown reasons, favored sorafenib. But again, here I wanna mention that that these drugs are different. So when I get the question whether second line we should do mTOR or a VEGF TKI, should we do everolimus axitinib, I think the field is open. We actually don't know. If you want to extrapolate from the trial, I could say that yes, temsirolimus and everolimus are both sirolimus analog and prodrug of everolimus, but they're different. They have different PK. One is IV, one is